oxygenated blood and then direct it towards the body. But in an overriding aorta, it is positioned towards the right. So it actually sits just above the VSD. Because of the VSD, oxygenated and deoxygenated blood can mix just below the aorta. So this mixed blood is then going to be pumped across the body, so the patient isn't going to be 100% saturated. They will appear cyanosed. And finally, you've got right ventricular hypertrophy. And this really is a consequence of the previous defects. So hypertrophy means enlarged. So the right ventricular hypertrophy refers to the enlargement of that right ventricle. And this occurs because it is a muscle and it is being made to overwork. Again, over time, that right ventricle is going to become quite stiff and it can become quite ineffective. And you can see how big it can grow here on this diagram. So in a Fallot's, this defect is present because of the additional blood that's going to be shunted via the VSD from the left ventricle, and also the obstructed pulmonary valve against which this right ventricle must pump. How does blood circulate through the Fallot's defect? Well, as with an anatomically normal heart, you've got your deoxygenated blood that's going to enter the right side by the IVC, and from the lower half of the body, the lower half of the body via the IVC and the top half of the body via SVC. It's then going to flow into the right atrium, then into the right ventricle via the tricuspid valve, which is here. At this point, again, it's important to remember that blood will always flow to the path of least resistance. The direction of the blood from the right ventricle is going to depend on the anatomy of the defect. If the pulmonary stenosis is mild, so the stenosis here, some blood will be able to flow through the pulmonary artery to then reach the lungs. However, because the left ventricle is at higher pressure, you're also going to have additional oxygenated blood, which will shunt from the left side into the right ventricle to also travel to the lungs. If the pulmonary stenosis is severe, blood will struggle to flow through this pulmonary artery and instead will shunt across the VSD into the left ventricle, and this is known as right to left shunting. The blood that has travelled to the lungs will return into the left atrium, so it's going to come via your pulmonary veins here into your left atrium. It's then going to reach the left ventricle, where depending on the degree of pulmonary obstruction, it's going to mix with the deoxygenated blood from the right. It's then going to enter the aorta and into the body. Some key signs and symptoms. So these can very much depend on the severity of this defect and the effect of the pulmonary stenosis, the size of the VSD, and the pressure that's going to be exerted onto that right ventricle. Cyanosis is obviously a key sign of Tetralogy of Fallot. Again, the degree of which will depend on the severity of obstruction and that degree of mixing of oxygenated and deoxygenated blood. For children with mild pulmonary stenosis, some deoxygenated blood will be able to flow through that obstruction and enter the pulmonary system. This blood will then be able to be oxygenated, and these children will appear more pink. Children with severe pulmonary stenosis, on the opposite, will appear more blue, so they're going to look more cyanosed. And this is because that deoxygenated blood will struggle to flow through the obstruction into the pulmonary system to be oxygenated. Instead, it's going to shunt into the left ventricle, where it will mix with oxygenated blood. Congestive heart failure can also develop over time. If the pulmonary obstruction is mild, blood will flow freely into the pulmonary system. Due to that VSD and the overriding aorta, there will be a greater degree of blood from the left ventricle shunting into the right. To pump this, additional blood in the right ventricle is going to have to work harder. It's going to become increasingly hypertrophied. The pulmonary system will also receive this additional blood, which can over time cause an increase in pulmonary pressures and can lead to pulmonary hypertension. As the heart then becomes unable to adequately pump, fluid can build up, and this causes congestion. And I know Kay mentioned this on the previous session, but congestion, I very much as well see it as the A1. Okay, traffic can't get anywhere, it's just going to pile up. The patient will then become breathless, they can become lethargic, You might see notable edema, and they can actually experience some cardiac arrhythmias as well. The infant with the Tetralogy of Fallot may struggle to feed, and then their weight gain might be quite poor. They can also be quite susceptible to chest infections and sepsis. Should you examine the child, you will have an audible murmur. So a quick note about the child with critical fallows. So this will be someone who's got critical pulmonary stenosis. They will be dependent on a large VSD and the fetal patent ductus arteriosus, or the PDA, and this is going to allow blood to flow into the lungs. So the VSD will allow deoxygenated blood to shunt from the right ventricle into the left, and it's then going to enter the aorta. In the presence of a PDA, the aorta, which is at a higher pressure, will allow the shunting of some of this blood to go to the pulmonary arteries and into the pulmonary system, where it can then return oxygenated into the left ventricle and then round the body. These babies will require immediate access and a prostate infusion from birth, and this is to maintain the patency of this duct, which we know will close within a couple of days of life. If these children are undiagnosed, they will present at this point with increasing cyanosis, signs of shock, respiratory distress, and that's as this PDA begins to close. So the TET spell. Now this is a really unique presentation of a Tetralogy of Fallot defect. It's a sudden and severe reduction in pulmonary flow, and it's what we call a spell. So this occurs when the right ventricular outflow tract experiences a spasm, and this reduces blood flow through the pulmonary artery, suddenly increasing the right to left shunting of blood into the left ventricle. The child's then going to become markedly cyanosed, and this can happen really quite quickly. Their respiratory rate is going to increase, the respirations will become really quite rapid and deep, and at this point the child is going to become extremely irritable and unsettled. During quite severe spells, cardiac output can actually decrease, along with cerebral hypoperfusion. I've never really seen it happen, but they can also lose consciousness at this point as well. So they can be quite scary to witness. Immediate management, well, 100% oxygen. This is going to increase pulmonary blood flow. Also, bending the child's knees will increase venous return and increase the systemic vascular resistance as well. So this is all to try and reduce the right to left shunt. So instead, increasing the pulmonary blood flow. If you read up on this, you can actually see children in developing countries with Tetralogy of Fallot, and they can be seen to instinctively squat, and that is their attempt at trying to force blood into their pulmonary system. One of the biggest things you can do, simplest things you can do, is to try and calm the child. Encouraging the parents to hold them, which, you know, this can be scary, but try and get them just to give them a cuddle. It can be really effective at trying to break that spell cycle. If these methods are unsuccessful, further medical management might actually be necessary. These can include sedation or analgesia in the hope that that will try and relax the spasm. Morphine can also improve hypopnea. This is done by suppressing the respiratory system. If it's quite a severe spell, a rapid fluid bolus can improve that by increasing that cardiac preload. And sometimes the introduction of vasoconstrictor can increase that systemic vascular resistance, and thus trying to reduce the right to left shunting of blood. If these continue, some children might require longer term management to reduce the incidence of their spells, and this can include the introduction of a beta blocker, which is usually propranolol. And if they continue and are quite severe, some spelling infants can actually require a PICU admission for intubation, mechanical ventilation and inotropic support. And really, regular spells that are increasing in severity is an indication to us that they're ready for a surgical repair of their fallows. So what does the surgery entail? Okay, so it can be corrective or it can be palliative, and this is dependent on the severity of the defect and the symptoms that the child's presenting with. If possible, it is preferred that surgery is performed on children over 4 months of age, but with